Hi everyone! I wish I could be with you live, but as you can imagine, my schedule has quickly filled up with preparations for the Inspiration 4 mission to space. This is such an incredible time as we embark on this unprecedented all-civilian mission. Thank you for having me today to talk about my journey from cancer survivor to physician assistant to civilian astronaut. And most importantly, I'm here to tell you about the importance of hope. When I was just 10 years old, I was diagnosed with osteosarcoma, or bone cancer. I had pain in my left leg, and a bump grew just above my knee. When the doctors diagnosed me, we all burst into tears. I was with my parents, and I just said, I don't want to die. Just a couple of days later, after a doctor's referral, my family and I were on our way to St. Jude. I went through a dozen rounds of chemotherapy and surgery to remove my knee and part of my thigh bone. The doctors implanted a temporary prosthesis that could expand with my leg as I grew up. I had to relearn how to walk. I should also mention that after my treatment was complete, I received the HPV vaccine at age 12. As a childhood cancer survivor, it was incredibly important for me to minimize the risk of certain cancers. After I completed my treatment, my dream was to return to St. Jude to give back to the place that saved my life. I'm now a physician assistant at St. Jude, and I work with leukemia and lymphoma patients. I can tell my patients, cancer is going to change you, but it's going to make you who you are, and you're going to be so much stronger because of it. I believe that anything is possible. I believe in the power of hope, and I'm incredibly honored to represent the Hope Seat on this unbelievable adventure as part of the world's first all-civilian space crew on a mission called Inspiration 4. The mission will take me and the crew to a lower Earth orbit where we will circle the globe every 90 minutes or so for 3 days. The most exciting part of this mission for me will be to interact with St. Jude patients from space. My selection for this mission truly embodies the power of hope. Not only will I be the youngest American in space, but I will be the first childhood cancer survivor and have the first artificial joint in space. Typically, you have to be physically perfect to be an astronaut, but this mission has truly made it possible for people like me to go to space. I know this trip will change my life. It's incredible to be part of this mission that is not only raising crucial funds for the life-saving work at St. Jude, but also showing cancer survivors that they can do things they never dreamed possible. A vaccine to prevent cancer is truly another dream come true. My cancer couldn't have been prevented, but through HPV vaccination, HPV cancers in adulthood can be prevented. The St. Jude HPV Cancer Prevention Program is a proud member of the National HPV Vaccination Roundtable. While I am reaching new heights, I know all of you also are working to reach new heights. Thank you for what you're doing to prevent HPV cancers and to promote that HPV vaccination is cancer prevention.
And thank you to Haley. That was fantastic. I'm a huge new fan. Good afternoon, everybody. I'm Kristen Oliver, a pediatrician and a preventive medicine physician at Mount Sinai Hospital in New York City. I'm the designated representative of the American Academy of Pediatrics to the HPV Roundtable.
Hello, I'm Rebecca Perkins, a practicing OBGYN and representative of the American College of Obstetrics and Gynecologists. Together, we have the honor of serving as co-chairs for the National HPV Vaccination Roundtable.
We welcome you all to the second and final day of our national meeting. Welcome back if you were on board with us yesterday. And to answer a burning question, yes, Rebecca and I are live, right, Rebecca? And yes, we are wearing the same fabulous HPV Roundtable National Meeting t-shirts that we wore yesterday, but not as cool as Haley's. This year, we're on a journey to reach new heights of adolescent vaccination rates, and we're really pleased that you're joining us. We have nearly 70 organizations in our coalition representing provider associations, survivors, academics, cancer centers, immunizers, public health organizations, health systems, and more. Our mission is to prevent HPV cancers, and our vision is to work towards elimination of HPV disease as a public health problem. For those of you who were not able to join us yesterday, we'll give you the Twitter version of what we hope to accomplish together. Due to COVID-19 healthcare-related disruptions, childhood immunization is down over 11 million doses in the public sector alone. This has huge implications for the future of vaccine-preventable diseases, including HPV. Our collective mission at this meeting is to get adolescent immunization back on track. Even if you're not on social media, the power of your organizations can magnify this message. If you are on social media, I challenge you today to tweet more about us and try to beat Dr. Heather Brandt in the number of tweets about this meeting you can get out. It is a strong challenge, but somebody might be up there. And thank you, Dr. Brandt, for all your tweeting yesterday. While we may not get quite at the level of 158,000 likes, we can improve the quality of care of thousands of preteens through today's content.
During the meeting, we'll be asking for your input via a Slido poll. If you were with us yesterday, you should be a Slido pro by now. However, practice makes perfect. So get out those phones or fire up those web browsers. For anyone new to Slido, take a look at the pixelated square on the screen. That's called a QR code, and you can use it to respond to Slido polls. To join with your smartphone, open your camera app and point it at the screen. The poll will open in your phone's browser. If you are feeling more Apollo 11 than SpaceX, feel free to join via your browser. Go to slido.com and enter in the participant code HPV 9922. Let's practice with a word cloud. We would like to get a sense of how our attendees feel about catching up on adolescent vaccination this summer. We'll give you a few seconds to see what kinds of new heights you want to travel to together. This is great. People are ready, they're optimistic, they're hopeful, some feeling a little overwhelmed, not, understandable given the past year we've all had. We can do it, determined, relieved, ready, committed. People are feeling the urgency. People are feeling motivated and driven.
There are a couple overwhelming. We're going to hopefully, situate everybody with some tools today too that can help address those feelings and leave you with some positive energy to move forward with that.
Yep, absolutely. Great. And keep your phone and browser handy for the rest of the meeting so you can be and remain part of the conversation. Kristen, how are you feeling about catching up on vaccinations this summer?
Not to steal Haley's keyword, but I'm feeling pretty hopeful about the work ahead of us. I'm hopeful we can get adolescent vaccination back on track for kids, regardless of where they live or their insurance status. And speaking of location-based vaccination rates, let's do a quick knowledge check. Everybody ready? Slido's out. What 3 states have the highest up-to-date HPV vaccination rates based on the 2019 NIS teen data? Get ready. I am, of course, sad that New York isn't on here.
Massachusetts is.
I know. All right, we'll give people, we've only got 80 for 90. I'm going to give another minute or two, not quite, to let people get some responses in there before we go ahead and show you the results. I know who Rebecca's going to vote for.
Of course.
And all right, let's go ahead and show the results then. The top 3, and the correct answer is Massachusetts, North Dakota, and Rhode Island. I believe Dr. Rebecca Persons is personally responsible for those high rates in Massachusetts.
That would be not true, but I do feel like the North Dakota rates may be due to, we had a fantastic presentation a couple of years ago at this meeting by someone who was personally raising the rates in North Dakota, and I think that might be why they're in the top 3 now.
I'm with you. It's okay if you did not get 100% correct on this quiz. Our presenters are going to help bring you up to speed. You might say high up in the atmosphere. On our first panel today, we will hear from national experts on the current data on geography and insurance as determinants of HPV vaccination. A reminder that the speaker bios are all posted on our meeting webpage, and staff have also posted in the chat. Dr. Brandt, the captain's chair is all yours.
My name is Heather Brandt, and I direct the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. I'm pleased to serve as the moderator for this panel session, The Atmosphere Matters, Current Data on Insurance and Geography as Determinants of HPV Vaccination. In this session, the presenters will share information about how where we live affects HPV vaccination rates, including recent research findings on effective interventions in rural communities, and explore how immunization registries and geographic data mapping can target areas of low vaccination. Yesterday, we learned about HPV vaccination in diverse racial and ethnic communities, and where we live matters too. the atmosphere matters, the context matters, and importantly, the presenters will discuss how we take this research on key HPV vaccination determinants and apply it for action at the state level. Geographic disparities are significant in HPV vaccination. In this map of the United States showing recent NIS team data, you can see the discrepancies, especially in the South and Intermountain West. Across the South, in particular, Mississippi has the lowest uptake of HPV vaccination at 30.5%, and Louisiana has the highest at 59.5%. The mean across southern states is about 49%, which is a full 5% lower than the US average. So while there have been improvements, geographic disparities persist. Rates can also differ significantly within a state, territory, or jurisdiction. If I were to show you a map of HPV cancers in the US, you would see in these areas with the lowest HPV vaccination uptake that there are the highest rates of HPV cancers. We must identify regionally appropriate strategies to account for the uniqueness in geographic regions with low HPV vaccination uptake to prevent HPV cancers. To take this one step further and integrate insurance coverage, there are 12 states that have not yet expanded Medicaid, with 8 of these in the southern US. A recent study published by Hoff et al. On the association between state Medicaid expansion and HPV vaccination showed significant increases in HPV vaccination after states expanded Medicaid. The largest increases were among individuals below the federal poverty level and among those with below $75,000 annual family income. In another recent and related study, Hawkins et al. Found provisions of the Affordable Care Act to be associated with increases in HPV vaccination series completion. And the results of this study suggest expanding Medicaid across the remaining states could increase HPV vaccine completion among publicly insured youth and prevent HPV cancers. HPV vaccination coverage in rural areas has been consistently lower as compared to urban areas in the US. From 2013 to 2018, the magnitude of the disparity between mostly urban and mostly rural areas did not improve, settling at the current difference of about 12.4 percentage points. Coverage was significantly lower among teens living in mostly rural areas, regardless of poverty status, sex, and race ethnicity, except among Black non-Hispanic adolescents. We are all more than one thing at any one time, and this is important to note when considering how we approach HPV vaccination interventions with rural communities. One of the presenters from whom we will hear today, Dr. Whitney Zond, led a review study to examine intersectional identity in rural communities to better understand the influence on cancer disparities more broadly. This work builds on work Dr. Zond has conducted previously in rural populations and cancer, including HPV cancers. Rural populations have an increased incidence of HPV cancers compared to urban populations and have experienced a statistically significant increase in HPV cancers. There also are differences within rural populations. Back to the point, we are all more than one thing at any one time. This means we have to consider local data sources, such as immunization registries, to target our efforts in rural areas. Dr. Natasha Askelson used data from Iowa's State Immunization Registry to examine the relationship between location and HPV vaccination initiation as one example to identify areas for targeted interventions. Now add in characteristics of people and places, and well, the atmosphere matters, and it matters a lot. We see differences in HPV vaccination across geographic regions and within them, such as in rural spaces and across the people who live there. So let's transition to the presentations for today's session. In today's session, you will hear from researchers who will reflect on the role of geography in HPV vaccination. These researchers have looked at key determinants, including rurality, area level factors, and insurance status, to consider factors that complicate or facilitate HPV vaccination. You'll also hear from ERA, the National Organization of Immunization Information Systems, about how stakeholders can leverage data for their own work. The bios for each of the presenters have been provided, and the presenters today are Dr. Bernard Femmler at Virginia Commonwealth University, Dr. Whitney Zond, at the University of Iowa, and Courtney Londo with the American Immunization Registry Association, and me too. Not only am I a moderator, but also will be presenting. We'll have just a short 10 minutes for conversation at the end, so be ready with your questions. What we can't answer live, we'll capture for later. I'll be presenting on HPV vaccination interventions in rural US communities to share the results of a narrative review I conducted with colleagues. In the background leading up to the presentations for today's sessions, I shared information on rural communities. Many barriers to HPV vaccination have been noted in previous research in rural communities. Low levels of HPV vaccination knowledge, lower overall childhood immunization rates, uptake of adolescent and adult vaccinations have also been shown to be lower. Healthcare provider shortages, lack of healthcare provider recommendation, and lack of transportation and distance. These and other barriers do not operate in isolation. They work together to create major barriers to action. To date, the majority of HPV vaccination research in rural US communities has used non-intervention study methods such as qualitative research, observations, surveys, and secondary data analysis to assess HPV and vaccine-related determinants. This research has been very important to understand the landscape of factors associated with HPV vaccination for descriptive purposes, but has resulted in limited guidance on how to increase uptake of HPV vaccination through interventions in rural settings. In contrast, the more broadly characterized HPV vaccination intervention research has shown that there has been less of a focus in rural communities. Rural communities are special to me. I grew up in rural northeastern Iowa in a small town with about 1,000 people called Fairbank. My upbringing shapes my work today as I reflect on my own experiences with rural communities and those of my many family members who still live there today. I'm reminded of the numerous strengths of these places, often thought of as remote, isolated, under-resourced, and more negative characterizations. There are so many strengths in rural communities: resiliency, self-sufficiency, assets indicative of collective strength, hardiness, and more. These are important, notable strengths that make up the fabric of rural life. However, these same strengths may make someone living in rural America less likely to seek preventive care. And this is particularly important with preventive actions such as HPV vaccination. So overall, for HPV vaccination interventions, there's this blend of evidence-based and recommended approaches focused on ensuring supply and generating demand. And these approaches work best in combination and are multi-level and multi-component, even multifactorial aspects within components to accommodate for context. So here is a snapshot of recommended approaches from the community guide. So while these evidence-based interventions may work generally, what about in rural US communities? What do successful interventions look like in rural US communities? The National Cancer Institute has emphasized a need for investment in rural cancer control, and HPV cancers are higher among people living in rural areas with lower HPV vaccination rates. So what do we know about how to change this? These factors led to our narrative review to examine intervention studies to increase HPV vaccination in rural settings and to summarize these study characteristics and outcomes. In our narrative review, we use systematic narrative review methods for studies describing implementation of HPV vaccination interventions in rural U.S. settings from 2006 to 2019. 15 studies met the inclusion criteria and were published from 2011 to 2019. These studies reflected multi-level approaches across patients and parents, healthcare providers and settings, and communities. And the intervention approaches included educational and communication strategies, provider recommendation, and addressed access to HPV vaccination. There were varying types and levels of engagement. The two most common approaches in rural settings were to address healthcare providers and systems and focusing on provider recommendations as a key determinant. Multi-level and multi-component interventions allow for implementation of myriad strategies to overcome barriers and enhance facilitators to HPV vaccination in rural settings. And there has been considerable emphasis on individual level barriers, environmental and system level barriers. Our review revealed mismatched evaluation approaches that did not correspond with the multi-level approaches. As Blake et al. And others have reported, the complexity of conditions in rural communities require equally complex interventions to address these disparities. Multi-level approaches consider resources, cultural values, geographic location, and economic status, among others. Implementation across multiple levels without evaluation of some sort across these levels limits the value for future replication and scalability. So for HPV vaccination intervention research, the desired behavioral change most appropriate to include is an HPV vaccination outcome, which was a requirement for inclusion in our study. But we found a need for greater consistency in measurement and reporting. There was tremendous variability in measurement and reporting that resulted in challenges in being able to even compare outcomes across studies demonstrating statistically significant results. Consistent measurement and reporting across multiple levels and for multiple components will aid in helping us to understand the most effective approaches to increase HPV vaccination in rural settings. Across the 15 studies, no study explicitly defined rural, and few provided important contextual information on the rural setting. This creates challenges for future replication and scalability. Reporting on these contextual factors, including those in the social, physical environment, the policy environment, and then among individuals, will strengthen our ability to apply these approaches in other rural communities. Another area of interest for increasing uptake of HPV vaccination in rural areas has focused on policy change. And policy changes can provide structure to support practice and shift social norms. To remove such barriers and increase HPV vaccination in rural areas, policy measures are needed with the ultimate goal of decreasing those disparities. So here we conceptualized policy change to occur across multiple levels and used big P and little p designations, understanding that both have the potential to increase HPV vaccination. Our efforts to increase HPV vaccination with rural communities are urgently needed, given the elevated rates of HPV cancers and low rates of HPV vaccination uptake. Strengthening the evidence base by accounting for rural context and also using what has been shown to work in other settings, being thoughtfully adapted for implementation in rural settings, can guide these efforts. Here I've summarized the many opportunities for improvement with rural communities. There's more attention being paid to HPV vaccination in rural settings. And we know there are emergent areas of research, including the role of social media, telehealth, and learning from vaccination approaches during the COVID-19 pandemic. In conclusion, we need more intervention research with rural communities and also better intervention research. Intervention research that accounts for context and is going to provide guidance on how to ensure approaches account for the strengths of people and place in the rural US. To reduce the burden of HPV cancers in rural settings and improve low HPV vaccination uptake, we need to understand methods and outcomes of HPV vaccination intervention research with rural communities. Rural populations are not monolith, and our intervention approaches should not be either. So we must ensure we put what we know into widespread practice with rural communities, and we are considering their unique needs and context. Thank you very much for this opportunity to talk about HPV vaccination in rural settings. We hope you'll reach out to engage with us in the St. Jude HPV Cancer Prevention Program. Thank you.
Thank you. I'm glad to be able to present today. I'm going to be presenting on some work that we've been doing looking at geographic variation in HPV vaccination. So the objectives of my talk today will be to provide a little bit of information on how HPV immunization surveillance is typically done. And then I'm going to talk a little bit about two papers that we have been working on in this area. One, a systematic review in which we're looking at papers that looked at area level variation in HPV vaccination. And another one where we're using GIS or Geospatial Analysis to look at identifying areas of disparities in HPV vaccination coverage. So many of you are familiar with the NIS Teens survey. It collects data from parents and on whether or not their child has been vaccinated. And then vaccination history is confirmed by the provider via mailed survey. So one of the pros of this is that it's considered really a reliable estimate at the national level. And sometimes for the states, they use this estimate too to surveil their coverage. The con is that the sample size per state is somewhat limited. And so with this limited power, it's hard to characterize smaller geographic areas, such as at the zip code level or even at the county level. Another method of surveilling HPV vaccination might be to use the state immunization registries. And many states have immunization registries. Providers report data on vaccines that they administer to children. Some of the pros of this is that it can be used to track the increase or decrease in immunization at small area levels. And it's really possible to identify high or low levels of immunization controlling for population size. And in many cases, residential addresses are available, so you can look at the places where children live where immunization is either high or low. And then sometimes data on the provider type and location where the vaccine was administered can be available, but not all state registries will release this information. Some of the cons of using this type of surveillance method is the denominator problem. Oftentimes it's difficult to determine the population prevalence for small locations if you only have data on the number of vaccines given, but you don't have any data on the number of teens that might be eligible. So data can be also very difficult to work with, sometimes millions of cases, and the data can be inaccurate. Sometimes providers without an EHR, it's difficult for the state to gain those data, and then provider compliance could also be low in some areas. So those are just some of the cons of that method. Another method might be to use electronic health records or claims data. This can be quite useful at identifying at a systems level how well and where vaccines are being administered. And it can be combined with other data to understand provider characteristics related to uptake. Now, the cons are that you still face this denominator problem, as I mentioned before, and also sometimes without special approval, the address of the teen or the child may not be available. So where the vaccine was administered may not represent where education efforts might need to be targeted, especially if patients travel far to see a provider. So this is just a snapshot of the NIS teens data. You can see here that I'm just highlighting Virginia, that's where I'm from, but you can see that our up-to-date coverage among females is around 41%, but look at the confidence interval, it's very wide, and it's really only a sample size of 129 females. And then for the males, it's 118. So very small sample size that is representing the full state for that method. So we were very interested in understanding what others were doing in this space, looking at how are people assessing area level variation in uptake. So we reviewed a number of different studies that looked at this research question, and we sought to conduct a systematic review and summarize findings from these studies. We used a keyword search through a number of different databases, including PubMed and others. And we included studies that provided information on HPV vaccination by geographic area level variables. And so we culled our list down to 25 articles from 733 that we identified. So some of the key findings were that most studies did focus on these large US geographic regions, and fewer looked at areas within the state. There was only three or four articles that reported on state level variation. Across these studies, the average HPV vaccination initiation was around 41%, and completion was around 23%. Some of the studies that looked at regions of the US, they were consistent in finding lower coverage in the southern region of the US, but there was inconsistencies with respect to other regions in the US, such as in the West or in the Northeast. Studies that looked at poverty at the zip code level did find that poverty was associated with higher vaccination rates. And with regard to rural and urban, there were some studies that looked at these differences, and there were some consistent results suggesting higher uptake in more populated areas, especially for boys. With regard to race ethnicity, many of the studies that looked at this did find that higher coverage was found in communities with majority Hispanic populations, and then there were mixed results with regard to communities with majority Black populations. And finally, studies were consistent in finding that there was lower initiation with higher area level uninsured and provider shortages. So these key findings suggest that one, well, there really aren't that many studies in this area. We only were able to identify 25 studies. And across these studies, they varied in the ways in which they were defining some of the metrics and initiation and some of the geospatial areas. So it was very difficult to synthesize findings across these studies. So we recommend that we need to standardize some of our definitions and improve the methods that we're using for looking at area level variation. And we need to incorporate spatial regression modeling approaches as well. Finally, there's a definite need to obtain data on vaccination coverage at smaller geographic levels. So the next study that we conducted was really to address the small area analysis, looking at Virginia in particular. And so we wanted to use geospatial analysis. So as I mentioned, there's some of the shortcomings of some of the other studies. And so our aim was really to model the variation in vaccination rates among boys and girls within Virginia and identify areas with depressed vaccination coverage and determine if there were neighborhood socioeconomic variables that might explain variation in HPV vaccination. The data source that we used was data from the Virginia Immunization Registry. We created an analytic sample of individuals born in 2001, 2002, and 2003 who were about HPV vaccination age ready in 2010 and 2018. So we took all the immunization records that were present for this birth cohort at the time, so their birth immunizations, and traced them into adolescents to look at whether or not they had received an HPV vaccination during their eligibility period. We used residential zip codes, and they were linked with several area level variables, including poverty, a number of 15 different area level variables. We used Bayesian hierarchical spatial regression models to identify geographic disparities in HPV. And then we used machine learning approaches to identify area level variables related to vaccination completion. So you can see here in this slide that lighter shades show lower vaccination completion. And overall, girls had high completion probabilities. Around 29% of girls and around 24% of boys had completed the HPV series. This map shows the data a little bit differently. The areas that are in dark red are areas of lowest vaccination completion. So you can see that in the Southwest, the northwestern parts, and areas of the Norfolk and Virginia Beach area have low vaccination coverage, as well as this large swath running from south of Alexandria through Sussex County. And with a few exceptions, really aren't that many differences between completion for boys and girls. So it's very similar maps for boys and girls. When we looked at what are the factors that predict whether or not there was vaccination completion, what we did find is that there was a higher probability of vaccination completion that was associated with a greater population density, a higher percentage of Hispanic population, consistent with our review article, and greater racial ethnic diversity, and higher percentage of residents with a college education. This is suggesting that vaccination completion is in areas of urban and suburban counties and zip codes. We found lower probability of completion associated with the average number of vehicles owned per household. And that might suggest that in more rural areas where rural residents tend to own more vehicles, farm vehicles, other work vehicles and such, that vaccination completion was lower. So of all the variables that we included, these are the ones that were significant in the model. So in summary, I'd like to just say that, different surveillance systems can really result in different estimates. Different methods for examining geographic differences can also result in mixed findings with respect to how estimates vary. And there really are very few good examples of using immunization data to estimate variation within the population. Our study is probably the fourth study that has done this. And then when done correctly, this could be useful in identifying areas where research could highlight reasons for hesitancy or where education efforts might be targeted, such as in precision public health strategies. I'd like to acknowledge some of my collaborators. It really took a team of scientists and students and scholars to make this work happen. And of course, my funding from the Cancer Center, as well as funding that helps support a postdoc working on this project. And of course, Christy Gray from the Division of Immunization at the Virginia Department of Health. So thank you very much.
Hello, my name is Whitney Zond. I'm an assistant professor at the University of Iowa in the Department of Health Management and Policy and a member of the Holden Comprehensive Cancer Center. I'm going to be sharing a little bit of work on access to vaccine for children providers and how that might help increase HPV vaccination for rural children and adults. Some of the other presenters have shared some challenges we see with HPV-associated cancers and HPV vaccination in rural populations. Rural populations have higher HPV-associated cancer rates compared to urban. And we also see that trends are poor for rural areas. So some study that my colleague and I have done showed that cancer incidence rates, HPV-associated cancer incidence rates increased over 19% between 1995 and 2013, while urban rates remain stable. So we see this higher HPV-associated cancer burden. And we also see that rural populations have lower uptake of HPV vaccination. So you see this chart on the right from Walker and colleagues that thankfully across all populations, urban, suburban, and rural, that the rate of vaccination initiation has increased over time, but we still see that it's only 59.3% in mostly rural areas compared to 70% in urban areas. So what do we do about this to improve the initiation of HPV vaccination to subsequently help reduce the incidence of HPV-associated cancers in rural areas? So there's a couple recommendations that both the CDC and a commentary by Vanderpool, Stratman, and Brandt, Dr. Brandt, who's moderating this particular panel, have shown that some ways to improve vaccination rates in rural areas are, one, to reduce the out-of-pocket costs for this. And one way to do that is specifically the Vaccine for Children program from the CDC as kind of a little p policy approach to increase vaccination in rural communities. So this CDC program, as many of you are aware, is a way to provide vaccines for uninsured children and adolescents, or those who are underinsured, Medicaid eligible, or American Indian Alaska Native populations under the age of 19 for any of the vaccines that are recommended by the ACIP. And so that includes HPV vaccination. And so with that, one of the things that my colleagues and I did in a recent study at my previous institution, University of South Carolina, we wanted to look at how accessible, from a spatial perspective, Vaccine for Children providers were in our state. So we obtained the Vaccine for Children provider locations throughout South Carolina. I did some spatial analysis, considering both the location of those providers and so the supply of providers, supply of that particular healthcare service, and the demand for that service, using the number of children under the age of 18 to create a spatial access score across zip codes in South Carolina. So you can see here on the map on the left, the areas in the garnet are the rural zip code tabulation areas, which is a geographic approximation for zip codes. And overlaid that are the locations of those VFC providers. And in the gray are the urban areas. Using the spatial method that we did, you can see the areas in the darker red are rural areas that have high access based upon that measure. And the darker blue are the urban areas with high access based upon that measure. And then the lighter colors of each, lighter hues or shades of each of those colors are areas where there's low access. So you can kind of see that here in the middle of the state as an example. So after that, just mapping those spatial access scores across zip codes, we did another spatial method, which helps us identify statistically significant geographic clusters of different values. So the areas in red or pink are called hotspots, and those are areas where there's high access, kind of geographically clustered. And we also overlaid that with, the cross-hatching here are the rural zip codes. And so you can see, for example, in this area that I'm circling right now, there's some rural areas that are hotspots for spatial access to Vaccine for Children providers. And we actually found there are more hotspots of access in rural areas. We also found, just looking at the mean spatial access scores across rural and urban areas, that the mean scores were higher in rural areas. So it's a little bit surprising, but this is also something that's good to see, that there's good access to these providers in rural areas. We also looked at this a little bit differently, not just by that spatial access score that it takes into consideration locations and the demand for the services provided at those locations, but also just simple distance. And we found there was no statistically significant difference in between the middle of each zip code to the nearest Vaccine for Children provider, whereas about 7.5 miles on average for rural zip codes and 6.5 miles to the nearest one in urban areas. We also looked at what types of clinics or providers were Vaccine for Children providers. And a key thing to note here is the plurality of rural providers were federally designated healthcare centers like FQHCs, rural health clinics, and other community health centers, as well as a larger percentage compared to urban that were at public health departments. Meanwhile, urban areas tended to have the majority of these clinics were at private clinics, or these providers were at private clinics. So I'm going to wrap up with just a few key takeaways from our study. One of the key things we found is that vaccine for children providers in the state of South Carolina are an accessible avenue for HPV vaccination among rural communities. We saw with the spatial access score that was actually higher across rural zip codes than urban. We saw similar average distances to the nearest VFC provider in rural zip codes compared to urban. We also demonstrated that spatial methods can help us identify areas where there's additional need for vaccine services. So using spatial approaches to describe the spatial access within an area and using those clustering analyses to help us identify hot and cold spots, it can be helpful for showing where there's additional need for those services. Also identifying where certain VFC providers are located and what types of providers those are can help us inform the planning and delivery of different interventions. So we found in rural South Carolina, the plurality of VFC providers were in federally designated health centers. And so there's really an opportunity to meet those rural patients where they are. About 1 in 5 rural patients get their care at FQHCs, for example, and many also get their care at rural health clinics. That's an opportunity to provide these vaccine services where patients are already seeking their care. It's also an opportunity to build upon the tremendous amount of resources that are being poured into rural health clinics and FQHCs for the COVID vaccine to go forward and use that momentum to help increase HPV vaccination in rural areas. So with that, I want to thank you all for your time and participation. I'm happy to take any questions during the panel, or please feel free to reach out to me if you have any further questions. My contact information is listed here. Thank you.
Hi, I'm Courtney Londo, and I'm here today to talk about ERA's Vaccinate with Confidence project. The American Immunization Registry Association exists to support and promote the use of immunization information to ensure healthy communities. We achieve this through building partnerships, advocating for IAS funding, sharing knowledge, and developing and promoting IAS standards. ERA's members are IAS staff working in health departments, IAS implementers, nonprofit and for-profit organizations, and currently ERA has more than 700 members. IAS are confidential, population-based, computerized databases that record all immunization doses administered by participating providers to persons within a given geopolitical area. IAS can do many things noted here on the slides, and a few examples are exchange data with multiple providers, and generate reminders to ensure timely vaccination. ERA is participating in CDC's Vaccinate with Confidence program. This is a strategic framework to strengthen vaccine confidence and prevent outbreaks of vaccine preventable diseases. ERA's specific goals within the Vaccinate with Confidence framework are to improve the capacity of immunization programs to use their IAS to identify pockets of low vaccination rates, and to increase the capacity of IAS staff to respond to vaccine preventable disease outbreaks. Smarty Streets is an address cleansing and geocoding service that's offered free of charge to all ERA member organizations who have a signed partner agreement. Using Smarty Streets increases our members' confidence in the quality of their IAS data. We are actively engaged in providing technical assistance to our members in the area of data visualization. The COVID-19 pandemic has highlighted the importance of building IAS data confidence and creating visuals that are engaging, interactive, and easy to understand for a variety of stakeholders. To date, we have conducted 3 Tableau trainings reaching 49 individuals across 19 jurisdictions. The Tableau user group kicked off in January. This group encourages peer-to-peer relationships between jurisdictions and creates a community in which members can share their successes and challenges related to data visualization. Recognizing that jurisdictions and immunization programs across the country are swamped with COVID-19 response efforts, we have implemented an EPI staff augmentation pilot. Our epidemiologist, Taylor Payne, has worked with a variety of jurisdictions to help support and augment their data analysis and visualization needs. So what can you do as an HPV immunization champion? You can develop an understanding of IAS data. You can connect with your jurisdiction's immunization program to access IAS data to inform your HPV projects. And examples include identifying and visualizing geographic and demographic pockets of HPV vaccination need, informing your campaign strategy, and using your limited resources, such as communications campaign dollars and staff time, in the most effective way. You can visit ERA's resource repository for a variety of materials on HPV vaccination. And you can learn more about small area analysis using IAS data in this resource, Identifying Immunization Pockets of Need. Thank you for your time today. Please feel free to contact myself or any of my team members. And we hope that you can join us for our national meeting in Portland, Oregon in August. Thank you.
Thank you to all of the panelists for those presentations, and thank you all for your excellent questions that are coming in the Q&A box. Please continue to post those there. We're going to go ahead and get started with asking our panelists, Dr. Femmler, Dr. Zond, and Courtney Londo, a few of these questions. So one of the questions that I think is for you, Dr. Zond, is can you further explain the difference between hot spots and cold spots for access to VFC providers?
Sure. Well, first, yeah, thank you very much for all of you being a part of this, and I appreciate that question. The key thing with the difference between hot spots and cold spots is it's a spatial statistical method to help us identify areas that have clusters of either, in this case, high access to VFC programming or low access. So the hot spots are areas where there is high access geographically clustered in an area, and the cold spots are the areas in blue on that particular map are those areas where there is low access clustered near each other. And so the ways that we can use those maps is particularly for the cold spot part is identifying, okay, this is an area of South Carolina or whatever geographic area you're looking at where there's less access to that particular programming. And maybe there's an opportunity then to reach out to clinicians or clinics in those areas with low access to engage them in potential enrollment in the VFC program. So that's just an example of how that can be used. So thank you for that question.
Thanks. And Dr. Femmler, this question is for you. So it's also a question I had. So Virginia enacted school entry requirements for girls only in 2008. They since have put the mandate in place for boys starting here soon. So how could that affect the data and observations that you saw in your study? Could you comment a little bit on that?
Well, I think that the mandate is kind of a soft mandate in Virginia, and so it is true that girls were mandated to get the vaccine to do school entry. But all the parent needs to say is that I don't want to do that right now, and they don't have to provide any reason. They don't have to get any kind of religious objection or anything like that. So it's pretty much a soft mandate. So I don't think that there's any impact that might have had on our data. I think we were looking at a time point after that, so all it would have been similar for all the time points. So yeah, I think the boys are being considered now, and I don't know if they're going to strengthen the requirement. We will see.
Great, thank you. This next question is perhaps for Dr. Zahn and Dr. Femmler. So have any of you taken these detailed geographic data on HPV vaccination and tried to overlay data with COVID-19 vaccination uptake? And what do you see when you're doing that? Especially from the vantage point of how hesitancy may have regional applicability.
I'm emailing my geospatial analyst colleague right now as we speak, because I think that's a great idea to kind of see if this is sort of a regional issue with regard to hesitancy, or if there's two different things going on here. So that's a really good suggestion, and we may look into that. Dr. Zahn, did you?
Yeah, Dr. Zahn.
Yeah, that's a great question and suggestion, and I think that gets to some of the questions I saw in the chat around the geographic precision of some of these data, as well as just the I think there's varying robustness in immunization registries that would enable or prevent sometimes these kinds of analysis depending on the state or some of those things. So I think there's certainly that's something I would be kind of interested in seeing personally, and maybe have some conversations with some people here at Iowa on that. But I think that's I guess the quick answer to the question is no, I haven't done that yet, but I definitely see there's an opportunity there to see where there are similarities in geographic areas that have low vaccination uptake, or other characteristics that might help inform interventions or education.
Yeah, I think if we do a quick look at the public data for COVID-19 vaccination and we look at top states and low states, there are similarities to HPV vaccination, especially differences in the southern US with some of the lowest uptake across both of those vaccines. So it is an interesting proposition to see what we can learn from the pandemic about how we might be able to connect that to inform actions for HPV vaccination. Courtney, we've received a number of questions about the capability of IISs to really get to that rural landscape level or smaller areas. Can you talk at all about how maybe ERA is working towards increasing the robustness or capacity of IISs to be able to do that?
Sure, I can certainly try. So can you hear me okay?
Yes.
Okay, great. So each IIS is governed by their own state through laws and policies, as we know, and this can create variations in data capture and use. And our executive director actually posted a resource that we have available on conducting small area analysis using IIS. It was included, the link as well, in my presentation. And so I think when wanting to drill down to pockets of need and look at HPV vaccination rates, especially in rural areas, as we know that can become identifiable, it's really important to work with your state health department and for them to know how important it is that you can use this data and how it will inform your decision making. So we know that setting this precedence and making sure legislators and leadership know how important the IIS data is, that can really be used to leverage decision making and to improve the data in the future. So it's state specific and it's jurisdiction specific, but I do encourage you to reach out to your state health department to talk about how you can best use that data to inform your campaigns.
Thank you. We also have another question here that this concept of a local champion that came into play. And so what are your thoughts about how we could also maybe foster local data champions to try to improve the data sources that we have to then better target our efforts effectively?
That's going to have to be our final question in order to stay on time on our mission.
Thank you, Mission Control. I was waiting for the prompt. Any thoughts on the champion angle?
Well, I can go ahead. I know that, having an HPV immunization champion is really critical, and having a provider with high vaccination rates can really foster that environment both within the clinic setting as well as to their peers. So having someone who knows the community, who's trusted, whose input is valued, and whose recommendations are really treasured is really important. And this person can really kind of bring everyone up to their level and encourage and really have everyone rise to the occasion by championing the effort.
Thanks, Courtney. And we'll have to wrap up. So thank you so much to our panelists for your presentations and for this discussion, and to everyone for your questions. We can continue to answer your questions in the Q&A box, and I'm going to turn this back over to Dr. Perkins in Mission Control.
Thank you, Heather, and thank you to all the speakers for an excellent panel. We do want to hear from you, the audience, as we close out this panel on geography and insurance as determinants of HPV vaccination. How can you apply the information presented by the panel? Do you need to think about it, take the information back to your team or organization, apply directly to your organizational strategies, or is it time to build new strategies? So please pull out your Slido. I see we have 15. The numbers are going up, but we have over 300 participants registered. So please pull out your Slidos and get to voting.
I think this is one too where we could have let people choose an all of the above potentially,
right?
As well. Need a little time to think about it. Then I'm going to play it, take that information back. You could do more than one. Just
exactly. Wonderful. And I think, the mission of the Roundtable, we convene, catalyze, and communicate. So being able to share information with you, to take information back to your teams and organizations is really part of our key mission. So we're very happy to see all those responses. And people can keep voting, but I think something we don't need to think about is the critical need to vaccinate boys and girls on time to prevent serious diseases, because we know vaccination is prevention. So once you already have HPV, the vaccination will not work because you've already got the disease. We know that HPV infection can lead to 6 cancers, and we know that HPV vaccination can prevent cancer. But did you know that HPV infection can also lead to a rare disease called recurrent respiratory papillomatosis? Here to tell us more about RRP is Kim McClellan, president of the Recurrent Respiratory Papillomatosis Foundation. Kim will be followed by the Tansey family. Thank you so much, Kim.
Good morning. I'm Kim McClellan, president of the Recurrent Respiratory Papillomatosis Foundation. And today, I'm going to be presenting on the connections between RRP and HPV, as well as the HPV vaccine. As we all know, recurrent respiratory papillomatosis is the most common neoplasm of the larynx that is benign. We know there's 2 types: juvenile onset, which typically occurs around the age of 4, and adult onset that occurs in the 3rd and 4th decade of life, based on reviews done by some of our most prominent researchers. We know that RRP is typically HPV 6 and HPV 11, and occasionally, especially in our adult onset, can be 16 and 18. Right now for RRP, there is no FDA-approved pharmaceutical treatment, and any pharmaceutical treatments being used today are all off-label. So what are the historical estimates of the prevalence of RRP in the US? This is where it starts to get so exciting. Prior to 2006, the RRP incident rate in juvenile onset was considered to be 4.3 per 100,000. At that time, and currently now, we estimate that roughly 15,000 surgical procedures are performed each year, with an estimated cost of $100 million. I want us to focus on the 4.3 incident rate of juvenile onset that was considered prior to 2006. Here are the current reports on RRP incident rates post-introduction of the HPV vaccine. In the United Kingdom, it now stands at 1.42 per 100,000. In the United States, remember the 4.3? Recent results in recent reviews are showing that incident rate to now be 0.5 per 100,000 since the introduction of the Gardasil vaccine. And in Australia, not only has it declined dramatically, but in 2019, the juvenile onset incident rate was 0. Yes, 0 new cases of juvenile onset in 2019. The HPV vaccine matters. Thank you so much for this opportunity today. The RRPF is so grateful. And now we'd like to share with you Eden's story and her journey with RRP.
Hey, look out, Lucas, here I come. I'm burning whiter than the sun. You don't scare me, I'm not shaking. Nothing's gonna slow me down. Nothing's gonna stop me. Nothing's gonna stop me now.
Good job. Eden is just an amazing child. She loves to learn. She loves to paint, sing, and be creative.
She loves to dance and twirl. She's curious about everything. She's a lot of fun to hang out with.
Throughout that first year, she seemed a little bit quiet. Her cry was quiet, and she wasn't babbling as much as other kids.
She was having all sorts of symptoms of labored breathing, and you can really hear it.
When she was about 1.5 years, it kept getting more pronounced. So I took her to the ENT.
He scoped her and immediately said, "We've got to go to surgery."
I was floored. That was the last thing I was expecting. He said that she was breathing through the tiniest pinpoint of an airway, that her airway was 90% obstructed.
And so we went to surgery the following morning. They removed what we thought was just a polyp.
When the doctor came back out, he said, "It's not what I thought it was. It's recurrent respiratory papillomatosis."
We didn't have any idea what that was, and he called it RRP. He said it's rare, that there was no cure.
When we got to the hospital room, she was just crying and confused, and it just broke my heart to think of her having to go through this.
It's devastating to a family not knowing if their child's going to live.
RRP is the most common benign neoplasm of the larynx. This manifests as lumps, growths, or warts that occur frequently on the voice box, including the vocal cords and the surrounding tissue. The mainstay of treatment is surgical excision. Unfortunately, despite the fact that we are able to remove the visible lesions, they tend to come back. Some children have had dozens or even hundreds of procedures in the operating room by the time they reach adulthood.
I had 32 surgeries.
It's a very unpredictable way of life. Sometimes the inflammation from surgery causes her to have no voice for 1 to 2 weeks. Sometimes every 30 seconds she's coughing, and every little labored breathing scares us. Is growth coming back? Do we need to get into surgery right away? We don't want her to be struggling breathing, but we also don't want to be going into surgery every 2 weeks.
Good morning, surgery too.
Love you.
Yeah.
The other thing that affects her is her ability to participate in activities. She loves gymnastics, taekwondo,
but it's more taxing on her. She would have to work harder to take a breath that most of us take for granted. So that has caused her to sit out on certain things.
They can't run with the other kids and be free. They're living a life with this hanging over their head, whether they'll be able to breathe or if they're going to choke in their sleep.
And as she gets older, she's questioning things a lot more now. She's asking, why do I have to go to the hospital? Why does nobody else in our family have this? Why did God choose me to have this disease? I don't want it.
You can see there's a frustration. She wants to scream sometimes, and there's times where she wants to belt out a lyric. You can tell she's trying everything to yell it out, and it's just a soft whisper that comes out. And I think it's frustration of not having that voice that she hears other people have.
And it's just utterly gut-wrenching and heartbreaking to have to watch your child struggle with that. We're constantly thinking about how to best keep her healthy and safe while giving her a full childhood.
We just hope that Eden can live a wonderful life. We really want her to feel like she's just a normal kid. And we hope that we can find a cure in her lifetime.
We would want her to just live her best life and her authentic, true self.
Thank you to the Tansey family for sharing that story and really bringing home to all of us the impact that HPV disease and RRP in particular can have on children and their families. And as well, thank you to Kim for sharing the really encouraging data that the huge drop in incidence in juvenile onset RRP, both here in the UK and in Australia. Rebecca, you had one thing you wanted to add?
Yeah, there's actually emerging data that HPV vaccination can be therapeutic in recurrent laryngeal papillomatosis as well. Studies where they've implemented vaccination, kids have had fewer recurrences and more time between recurrences. So this may be one of the rare instances. We normally think of the vaccine only as prevention, but it does seem to have an impact even on kids with the disease and to be helpful for them as well.
Thank you. It really is. I love HPV vaccine, as everybody knows, but it's good to know more and more reasons to love it. It's not every day you have a vaccine that prevents 6 cancers and a rare disease that affects children and adults. This is why really it's so critical that all kids get vaccinated on time. Data continue to show HPV vaccine is safe and effective. In fact, we're no longer the new vaccine kid on the block, thanks to COVID vaccine. Yet HPV vaccination rates remain well below national goals of other vaccines that are part of the adolescent platform. Even before the disruption to healthcare during COVID, lagging HPV rates were a problem that required innovative thinking to solve. Yesterday, we heard compelling remarks from Dr. Spinner on starting HPV vaccination at age 9. Our next panel is going to expand on the promising evidence starting on age 9 can increase on-time HPV vaccination rates. I will hand it over to you, Dr. Bednarczyk, to take it away. Thank you.
Hello, I'm Dr. Robert Bednarczyk, Associate Professor of Global Health and Epidemiology at the Emory University Rollins School of Public Health. I'm also a faculty member at the Emory Vaccine Center and the Winship Cancer Institute. I would like to welcome you to this session on best practices for HPV vaccination at 9 to 10 years of age. I have received research funding support from the National Institutes of Health, the National Vaccine Program Office, CDC, and the Bill and Melinda Gates Foundation. I have no other conflicts of interest to disclose. I would like to thank the staff of the National HPV Vaccination Roundtable, especially Jennifer Sienko, for all of the support and coordination to make this session come together. So in terms of HPV vaccine uptake, we typically see relatively low vaccination coverage among 13 to 17-year-olds assessed in the National Immunization Survey team compared to that of other vaccines. So as a point of reference for the Tdap vaccination, we're seeing coverage greater than 90% in that population, receipt of at least 1 dose of quadrivalent meningococcal conjugate vaccine at around 89%, but only 72% of 13 to 17-year-olds have received at least 1 HPV vaccine dose, with 54% of US adolescents up to date for the HPV vaccine series. That up to date level is very similar to the coverage seen for 2 or more doses of meningococcal vaccine at approximately 54%. And it's important to know that that recommendation for the meningococcal second dose came about only in 2013 and is recommended to be given at age 16. So there's even less time for catch-up, but we're still seeing coverage levels for that vaccine similar to that for HPV vaccination. So the recommendations that we have currently for HPV vaccination in the US, coming out of the CDC and coming from the Advisory Committee on Immunization Practices, read that children and adults aged 9 through 26 years of age are recommended for HPV vaccination, with a routine recommendation at age 11 to 12 years, and also an indication that vaccination can be given starting at 9 years of age. But the wording of this recommendation, in a way, almost makes this sound like an optional starting point. However, other professional organizations, including the American Cancer Society and the American Academy of Pediatrics, routinely recommend HPV vaccination between the ages of 9 to 12 years. When we look at coverage of HPV vaccine by 13 years of age, where we should expect to see coverage based on these recommendations, some prior work that we've done shows how we're falling behind. So when we look at the 2016 NIS teen data for all 13 to 17-year-olds, only 37% had initiated HPV vaccination prior to 13 years of age, and only 16% were fully up to date by their 13th birthday. So our young people are not being vaccinated fully in accordance with the existing recommendations. Another recent study that was just published in Pediatrics this month focused in specifically on the 13-year-old cohorts that are assessed in the National Immunization Survey team. And they evaluated initiation and completion of the series at ages 9 to 12 years. And interestingly, while they found a consistent increase in initiation at 9 to 12 years of age for these 13-year-olds, coming up to greater than 60%, completion, being fully up to date with the HPV vaccine series, has stagnated at around 32%, and it's stayed that way since approximately 2015. So why is it important to vaccinate adolescents starting at 9 to 10 years of age? Well, the ACIP recommendation does include this as part of their recommendation, and vaccination at starting at 9 years of age is routinely recommended by American Cancer Society and the American Academy of Pediatrics. Vaccinating early may preempt some parental concerns about sexual activity, as parents of 9 to 10-year-olds may be less concerned about the vaccine increasing levels of sexual activity than they may be for adolescents who are aged 11 or 12. And starting HPV vaccination at age 9 can also address parental concerns about the number of shots at one visit. For example, some health settings are giving the first dose of HPV vaccine at 9 years of age, the second dose at 10 years of age, and then following up with the Tdap and quadrivalent meningococcal conjugate vaccine at 11 years of age. So today, we'll hear from 3 leaders in this area of HPV vaccination starting at age 9 to hear about the current state of research and implementation on this very important topic. Dr. Rebecca Perkins is going to give us a little bit more of an overview of the situation, including outlining the components of a successful program to vaccinate starting at 9 years of age. Dr. Melissa Gilkey will speak to us about primary care professionals' perspectives on starting HPV vaccination at 9 years of age. And Dr. Sherry Zorn will share some of the successful clinic level experience that she has seen in her clinic with starting HPV vaccination at 9 years of age. So with that, we'll move on to the presentation from Dr. Perkins.
Hello, my name is Rebecca Perkins. I'm here from Boston University School of Medicine and Boston Medical Center. I'm one of the co-chairs of the National HPV Vaccination Roundtable, and I'm going to discuss today some components of a successful vaccination program for age 9. The most important thing is to start with a strong recommendation. This has been called by many names. This has been called a presumptive recommendation, indicated, announcement. It all means the same thing. It basically indicates to the patient in a non-confusing way that they are due for a vaccine today. It is very simple. It says you are due for the HPV vaccine. It does not sound like if you want, you can start the HPV vaccine, which prevents cervical cancer. If vaccination is presented as an option, parents interpret that as it being unimportant, and that is not the message that you want to give. Miraculously, doing something this simple is much more effective. Strong recommendations work better and people like them because they are clear and not confusing. We audio recorded 146 interactions and analyzed the conversations, and we found that 87% of the patients received vaccination following a strong recommendation compared to only 68% when the vaccine was presented as optional. Occasionally, the provider would suggest that the patient delay vaccination. If they were 11, they would say, oh, we recommend this at 12 or something like that. And in that case, even when the parent indicated before the visit that they were very likely to accept vaccination, they never actually got vaccinated. So it's very, very important not to discourage vaccination or put it off, because then it definitely does not happen. We also found that the indicated or strong recommendation was the most satisfactory to parents. They liked it better, and more parents were dissatisfied when vaccinations were put off. We also found that starting with a strong recommendation saves time. We looked at 106 vaccine discussions across 82 clinical encounters with 43 different providers, and we found that vaccine discussions were significantly shorter when the recommendation was given in a very simple way. You are due for HPV vaccine. On average, those conversations took a total of 74 seconds compared to 140 seconds. And you can see parents still felt perfectly welcome to ask questions if they wanted to, but it just was a more clear indication of what was supposed to happen at the visit. And so it didn't generate as much confusion, and the conversations were more helpful and more satisfying to patients. The odds of vaccination were also substantially higher, 9.3 times higher following a strong recommendation. And the discussion length and presentation style were again not associated with parental satisfaction. What was also good to know is that you can teach this. It's not a natural thing to be a good vaccine recommender or to have a magical touch with parents to get them all to vaccinate. It's actually a skill that can be learned. We designed a program called Development of Systems and Education for HPV Vaccination to increase HPV vaccination rates. The core principles of the program were repeated contacts, education on the facts of HPV, as well as how to give a strong recommendation, and then quality improvement support. Providers were incentivized to participate by receiving MOC and CME credits. The key intervention components were education on a strong recommendation and initiation of the HPV vaccine series before the age of 11. So we found that when we audio recorded the clinical interactions before and after the intervention, the use of a strong recommendation increased from 62.5% before the intervention to almost 80% after the intervention. The providers also all agreed to start initiating the vaccine series before age 11, 3 practices at age 9, and 2 practices at age 10. And while providers were originally nervous about removing HPV vaccine from the adolescent bundle, when we asked them how it had gone, they said it was easier than I thought. Their initial concerns about removing the HPV vaccine from the adolescent bundle were not confirmed. They uniformly reported high parental acceptance, reduced stigma relating to sexual activity, and found that the parents really liked the opportunity to administer fewer shots at each visit, as well as the children obviously preferred fewer shots. They also felt that It provided more opportunities to complete the HPV vaccine series on time. One provider says, "We present it as this is a shot that we recommend, and it prevents cancer, and it's more effective when kids are younger. And if they get it now, they don't have to have it when they have the other 2 shots when they're 11. Those 3 things seem to convince most people that it's a good idea." We also found that the vaccine initiation was increased. The likelihood of a child getting a vaccine at a visit where they were due increased by more than 10 percentage points, and the likelihood of starting the series in the population overall increased from 75% before the intervention to 90% after the intervention. We also saw an increase in completion of the vaccine series from 60% before the intervention to 69% after the intervention. And what we were really excited to see was in one of our practices that continued to give us data for 4 years after the intervention was completed, we saw their vaccine series completion rates continue to rise. So this graph looks at the HEDIS measure, which is a measure of on-time completion or completion of both doses of HPV vaccine before the 13th birthday. And you can see when the practice started the intervention in March of 2016, they had about 62 or 64% of their kids completing the series by age 13. And by October of 2020, and remember, this is despite COVID, they were up to nearly 87%. So just a steady, tremendous increase that they attributed to starting the vaccine series younger. So in summary, you can change practice culture. The key components are a strong recommendation and starting the vaccine series at 9. This can lead to sustained improvement in on-time completion for years beyond the initial intervention. We also noted that electronic medical record prompts can be helpful to sustain behavior despite provider turnover or other changes in the clinic situation. Thank you very much.
Hi, I'm Melissa Gilkey, a behavioral scientist and associate professor at the University of North Carolina's Gilling School of Global Public Health. In the previous presentation, we heard some good reasons to recommend HPV vaccine as soon as possible, starting at age 9. In this presentation, I'll share some recent data that suggests that some primary care professionals have already adopted this practice, and many others may be ready to get on board. The aims of this study were to evaluate primary care professionals' perspectives on recommending HPV vaccine at age 9. More specifically, we wanted to assess their current practice in terms of when they were recommending HPV vaccine. And for those who weren't recommending at age 9, we wanted to know how willing they might be to start doing so. We also wanted to understand what PCPs believe to be the advantages and disadvantages of recommending at age 9. To reach these aims, we conducted a national online survey of primary care professionals that we fielded in February and March of this year. Participants were members of a standing panel maintained by a survey research company, and they were eligible to participate if they had a role in providing vaccines to adolescent patients ages 11 to 17. Our final sample consisted of 1,047 PCPs. About 2/3 were physicians, with the remainder being advanced practice providers, so in other words, nurse practitioners or physician's assistants, or nurses. Just over 2/3 worked in family medicine clinics, while the others worked in pediatrics. Most had a good amount of practice experience, so 10 or more years. Our response rate was 61% for physicians and 41% for advanced practitioners and nurses. Let's look at some of our findings on HPV vaccine recommendations at age 9. So again, we first wanted to understand PCP's current recommendation practice, and we found that about 1/5, 21%, reported that they were already starting their HPV vaccine recommendations at ages 9 and 10. And we can compare this to 59% who said they recommended at the traditional target age of 11 to 12, and 20% who said they started recommending at a later age or never. So a sizable minority were already using age 9 recommendations. We next wanted to know, among PCPs who weren't using age 9 recommendations, how many were willing to adopt that practice? We found that about 1/5, 22%, said that they were very or extremely willing, while 39% were somewhat willing. And we can put these two variables together in the context of our full sample to think more broadly about support for age 9 recommendations. We can see that taken together, over 2/3, 69% of PCPs said that they either currently use age 9 recommendations or are somewhat or more willing to start using them. Now, our final aim was to assess PCP's perceptions of the advantages and disadvantages of recommending HPV vaccine at age 9. And here we're looking at the advantages, which PCPs selected from a pre-specified list. The top reasons appear to be about the potential health benefits. So over half of respondents said that recommending HPV vaccine at age 9 would have the advantage of protecting the child before HPV exposure and give the child a better chance to complete the HPV vaccine series on time. It's notable that only 12% of PCPs indicated that they didn't see any advantages to age 9 recommendations. And here's a look at the perceived disadvantages, with the top one being the perception that parents aren't ready to talk about HPV vaccination at age 9. Almost 3/4 of PCPs endorse this idea. The next most common response was the perception that it's uncomfortable to talk about sex with parents of younger children. About half of PCPs selected this option. And 8% of PCPs said they didn't see any disadvantages of age 9 recommendations. So to sum up, our national study found reasons to be optimistic about primary care professionals' support for starting HPV vaccine recommendations at age 9. Over 2/3 of PCPs in our sample were already recommending at age 9, or were at least somewhat willing to start doing so. Almost all PCPs saw at least one advantage to age 9 recommendations, including the chance to better protect children before exposure to HPV and to complete the HPV vaccine series on time. PCPs also reported disadvantages, and in particular, concern about parents not being ready for HPV vaccination at age 9. And this is interesting because that's what we used to hear about HPV vaccination at ages 11 to 12. And yet most of the PCPs in our sample reported that they now recommend it at those ages. Encouraging PCPs to adopt age 9 recommendations may require encouragement from others who have implemented it successfully. I'm excited to hear about 2 of those great success stories today when we hear from Rebecca Perkins and Sherry Zorn. So I'll wrap up here by acknowledging my collaborators and funders. I look forward to discussing this topic with you in the Q&A. Thank you.
Thank you so much to all of our panelists, to Dr. Perkins, Dr. Gilkey, Dr. Zorn for this great set of presentations. We've been monitoring the question and answer session right now, and we've actually got some really good questions, and I'm looking forward to hearing all of the discussions. So the first question that's come in is, I'll just put this out to the whole panel. What are some techniques to address barriers and help providers feel more comfortable when making the recommendations to start vaccinating at age 9? Dr. Zorn, has there been any specific experiences you've had in trying to improve that provider comfort level?
Well, I think the main thing is providing them an example and telling them that it actually can be done and it's not hard, and just demonstrating how to give a simple recommendation. And then just asking them to try to do it with one patient. I mean, we all know change is really hard. It's really intimidating, but trying it with one patient isn't a very big commitment. And once they do that, then they'll try it with their next one and their next one. And I think having someone that they can also go to for coaching and feedback is really helpful.
Yeah, that's basically exactly what we did in our study. And we had one provider who was very, very nervous, and, our great facilitator of the session where we did all the training said, just try one. And we, came back with the next session and she said, that was great. And then she was the biggest proponent because she had been so worried and then found it so easy.
When I had my providers in my group, I said, just if everyone could please commit to doing it with one patient, your next patient, either today or tomorrow. I didn't know that they would do it. And then literally that same day I got emails and texts like, I did it. It totally worked. It was really easy. And then I went around that, the next couple of days and made sure I personally talked to every provider to see what their experience was, if they're having any troubles. I actually wrote the script out and handed it to them in case they really needed to, they couldn't memorize the 2 sentences, and they found it was really helpful.
I think our survey data definitely reflect that same theme on kind of a nationally, that the most commonly chosen disadvantage that PCPs were perceiving was that parents weren't ready, this concern about the relationship with parents. So I love the idea of having providers try it, but also having these examples like Rebecca's and Sherry's of just how effective it can be. I think could be really energizing and maybe tip some people over from being hesitant or worried about it to at least trying it.
And I think that we were worried that we were changing the rules on the patients. In fact, our old posters said age 11, and then the providers went in and said it's going to be 9. And we thought, what are we going to do? The rules are changed. And basically we were able to just tell them, well, the science now shows it works better at 9. So that's why we do it at 9. And I only had one patient refuse to get it at 9 because she told me she wouldn't get it until I changed the poster to reflect the new recommendation. So I only had one patient who gave me pushback on that.
Yeah, we had the same experience. We audio recorded a lot of 146 interactions, and most parents weren't confused, and the ones who were, it was because they had an older sibling that they had vaccinated at 11 or 12. And then the provider said, oh, they changed it because it works better at fewer shots. And they basically all said, oh, okay, that makes sense. Mm-hmm. So it was really more of just not a hesitancy, but just, it was a change, and they asked about it and they got an answer and they were fine.
And I do think, in the experiences that both Rebecca and Sherry shared, show the impact of having that champion right there in the practice. And what I'm hopeful for is that what's coming out of this session and from everybody who's in attendance today, when they hear this, that they can take that back to all of their staff, all of their providers, everybody that they interface with and talk with, and use those examples so that we can spread this out more than just within the individual clinics that we're working in.
Yeah, and I think especially with COVID vaccines and being so behind, taking advantage of every opportunity to vaccinate within the CDC guidelines, it becomes even more of a priority.
The next question that we have here, and this is a fairly simple one, I'll just put it out there just for reference. Do we know if all insurance companies will cover the HPV vaccination being given at age 9?
Yes.
Simple answers to simple questions. Yeah, I'm with the Affordable Care Act, all ACIP recommended vaccinations, and even with the way the recommendation is written for 11 to 12, but with the allowance for vaccination down to 9, that does trigger that insurance coverage, so that should be covered without any issues. So this is a question that I'll put out. Does anyone know what the age 9 recommendation practices are among federally qualified health centers? So I personally don't work with very many FQHCs right now.
Our project was within FQHCs. I think FQHCs can follow the recommendations. Most of their funding is from CDC or Title 10, so they need to follow CDC recommendations, but age 9 is within CDC recommendations, and CDC, encourages people to follow their recommendations, and their partner organizations to make statements, and people could follow those recommendations as long as it's within the 9 to 26 age range. So FQHCs should be able to recommend 9 to 26 without an issue.
Yeah, I think as far as I know, I don't think that there's any specific recommendations or guidances that are out for FQHCs. But again, hopefully the messaging that comes out from this session, people will be able to take back to their clinics, especially the FQHCs. So one other question that's come in: how do you address parents who ask, why should my daughter get vaccinated when she'll get pap smears in the future?
I can take this one. Where to start and how to be quick. So the quickest answer is HPV vaccination prevents cervical cancer even among young women who get pap smears. So there's data from a Scandinavian study looking at young women who were vaccinated before the age of 17, all of whom were recommended to get pap smears every 3 years, starting at 23. And it's Scandinavia, so they probably did, unlike here where they probably don't. And it showed a near elimination of cervical cancer among the vaccinated young women, and a steady rise in cervical cancer among the other women, even in the presence of screening. So that is the quick answer. It will prevent cancer on top of screening. I'll just stop there. And the other, obviously, we don't have any screening for oropharyngeal cancers, vulvar cancers, penile cancers, anal cancers. There is no other prevention for recurrent laryngeal papillomatosis, and vaccination is the only way to prevent those.
Great, thank you. One other question, and again, I think this is going to a similar set of parental concerns. Could members of the panel discuss a perceived disadvantage to starting early, to starting at 9, with the idea that the immunity may not last long enough if you're giving it earlier? And how do you handle that in clinic?
I'll defer to Rebecca and Sherry about the kind of clinical response, but our survey work showed that was a concern for about 1/5 of the PCPs in our examples. So not all of them, but definitely some of them. And so a first step might be pointing to studies that show that HPV vaccination, that immunity has been monitored for more than 10 years and continues to look great. And this is one of the only examples we have of being able to start using fewer doses instead of adding more boosters, which I think is really encouraging. But Sherry and Rebecca, I'd be interested to hear what your response to this as well.
Yeah, I try to tell people, this has been monitored a really long time, and the modeling studies show that the immunity should last a very long time. And hey, there's 15 years of people ahead of us. So if we find out that we need a booster shot, this kid that you vaccinate at 9 is not going to be the first one who finds that out. They will have already found that out because there's 15 years of experience ahead of us. And we're not finding that the immunity is waning.
Yeah, that's a great answer. I mean, the studies do show the longest study of Gardasil is 14 years and it didn't wane. There are studies of the sort of vaccines of just the L1 capsid protein for HPV 16 that I believe still have not waned. There's even questions of whether we can go down to 1 dose to produce immunity. And I think that the design is really more like the hepatitis B vaccine, where you give it as a baby and it works for the rest of your life. So I believe this, as far as we know, we're not going to need a booster. So 9 versus 11 shouldn't be a concern for that.
Yeah. And I tell them, and if we need a booster, great, we'll do a booster.
Yeah.
No big deal.
And another strong piece for that as well is that, our immune systems have a great level of memory. And there's been some research where people who have been vaccinated were given an additional dose 5 years later. And we saw a very strong, very rapid response when those viral capsids were introduced again. So we know that there's that very quick response, even if antibody levels, do start to come down to a plateau. So I think that's just a hallmark of how good our immune systems are.
Right. And we also know that in the 9 to 14-year-old age group, they make a more robust immune response to all vaccines, including HPV vaccine. And now we've seen it in the COVID vaccine trials where their antibody rates are 3 times as high. So you get a much better immune response per dose in this age group.
So interestingly, as we were just talking here about, the stronger antibody response in younger populations, and this focus on starting vaccination at 9 and 10, I would be a little remiss to not bring up one of the questions that came in about discussing vaccinations for older patients. So I'll also leave that out for kind of the broader roundtable. And I know that the support out of the recommendation from American Cancer Society is to focus on vaccination up through age 26. We do have, we do have licensure and a permissive recommendation, shared clinical decision-making recommendation for ages 27 to 45 from CDC. But I think right now, really the main focus is working on both getting adolescents and younger adolescents back on track after COVID, but then also just getting everyone vaccinated as early as possible to provide that lifelong protection. So when we think about some of these issues, especially with some of the messaging that we see, and I know there's been Melissa's findings from her survey data, Rebecca and Sherry's work actually in the clinic setting. One question that I have is, we've seen this really good work in a clinic by clinic setting of implementing these. What are the holdups to being able to do that on a wider scale? We know what works. So your thoughts are as to why we're still seeing such low HPV vaccine coverage rates.
Do you want me to take this?
Sure.
Well, I think people need a permission slip, honestly. And even when that permission slip came to us, only 2 of us out of 11 were sort of even read it or were willing to do it. And a lot of people say, well, why are we going against the CDC? Like, tell me why we would go against them. I'm like, no, we're not going against them. We're going with them. We're just pushing them a little bit earlier. Everything we're doing is in full compliance with the ACIP recommendations. So I think people, they want to make sure they're not making a mistake and going against anybody. So I think that we need to get that message out. We need to make sure that they know they have a permission slip. Academy of Pediatrics needs to be stronger in their recommendation for HPV at 9. I found it hard to even find on their website when I was searching for it. So I think the permission slip's really important from a national basis. And I've had barriers in my own clinic. I mean, I'm in a big multi-specialty group. Pediatrics and vaccines are not a top priority at all. So we really just started from the ground up. And now finally, 3 years later, I think this summer we're going to get traction on changing our EMR prompt. But we didn't even have that for 3 years because it's just not a institutional priority.
I think that's such a good point. As a researcher and kind of a vaccine nut, I think it's always helpful for me to be reminded that for practicing pediatricians, this is one quality metric. It's one thing they do out of like hundreds of things that they're responsible for. And it's understandable that that it may take time for them to get this message and to try a new approach and to prioritize this above all else. And so that's why I think the roundtable is so exciting, is that we can help be that reminder and that prompt to get people to try new practices and to keep up with the HPV vaccine literature, especially in these cases in which it may actually save them time and make parents happier.
Yeah. And I think in my practice, when we started working on it, it was a big lift. I have to laugh at myself. I thought it would take us 3 months from September to December of 2016 to just whip it and shape and be done. And I had no idea I'd become more and more of an HPV champion all along. But I had to make it simpler because it was just too big of a lift what I was asking people to do. And that's why we kind of came up with our strategies. And then I figured with so much staff turnover, I had to bake it into our environment so that I didn't have time to retrain every staff. So the lobby poster literally trains the front desk people. They're staring at it all day long. Mm-hmm. And the vaccine poster in the exam room, that trains the MAs. I mean, keeps the MAs and the parents going the same direction and actually reminds the doctors too. And then the cue cards really help prevent the misinformation. And I want to announce, I guess, that the members of the Roundtable Steering Committee are working with me on developing a poster that can be used in every exam room in the country that's branded with the Roundtable that has a simplified vaccination schedule for teens, preteens and teens. My clinic has from birth to 21, but we would just focus on from 9 to 16. And I just want to say that that's coming really soon. And the cue card is in the approval process with ACS. We just made it for a pilot project, but we'd like to make it available for everybody.
It breaks my heart to say this. We only have time for one more question. I love all the conversation we're having and these fantastic ideas. One more question.
So the last question, this just came into the Q&A. This is maybe from a little bit more of an implementation perspective. Do you find that prompts in the EMR or smart set checklists for well child visits are useful for providers, or are they only useful if there's buy-in first? So a little bit of a chicken and an egg consideration of, can you implement these if you don't have full buy-in, and will people come or not?
So I think you do need buy-in first, because we, in our randomized trial, we had 2 sites that were on the same EMR, but because we were doing the intervention at different times, one site had the intervention and then had the EMR change at the end of their intervention, and the other site wound up getting it at the same time, but before their intervention started, and they wound up turning it off because they didn't know what was happening. And so I think it is but on the other hand, when the sites did it, when they had the intervention, which is really just like a couple of lunch meetings to get everyone on board, and then the prompt was there to remind them, those prompts have stayed in place for 4 years, and you could see the effect. The rates just kept going up and up, and then it protects against, you repaint the office and the poster comes down, the staff turnover, all of those things that Sherry mentioned about needing to have a constant reminder of, this is our practice now. The EMR prompts are extremely helpful. But yeah, people do need to know that they're coming, and so they like them instead of not liking them.
Yeah. And I would add, at the polyclinic, we have 11 pediatricians and about 50 something family medicine providers, and I've really only focused on the pediatricians. The family medicine providers have passive access to my lobby poster and my exam room poster, but I don't know if it's in their exam rooms. And they have sort of passive access to one of our well child smart sets for ordering. I don't know if they use them or not. There's another more generic smart set for them to use. But when I look to see, are they adopting this already? Even though I haven't trained them with the strong provider, rah team meeting, strong provider recommendation, I found that the pediatricians at the 9 to 10-year-olds overall, the kids, 77% of the kids get the vaccine, but family practice isn't far behind. I mean, they're at 25%, so that's not zero. So, just through passive knowledge transfer or access to the strategies without any team building on it, they're already adopting it.
It's like herd immunity.
It's absolutely like herd immunity.
And I think you had 90% protection when you get the vaccine yourself, 34% protection when it's passive for the other people. So that's actually pretty much the way that looks.
I thought you'd jump all over that.
Yeah. And so they won't be surprised when they get the email saying the prompt's changing and Sherry says it's changing. They'll be like, all right, yeah. And then I probably need to go talk to their whole team and just give them a rah lecture. And I'm happy to do that, but it's just interesting that passive versus active participation.
Fantastic.
Thank you all so much for this session. I really appreciate hearing all of this and Q&A. Yeah, I'll turn it back over to the roundtable.
Thank you so much. That was fantastic. Love listening to all of you. We definitely have clear transmission from the best practices task group. Thank you so much. I feel like it's time for Slido. I know, Rebecca, Dr. Perkins, what you would say, but everybody else watching and listening today, what actions do you expect to take after hearing the evidence for vaccinating at age 9? I am going to vote too. All right. And if you still need the code or open this by your web browser, in the chat box is the link and the code. All right. We have lots of folks who are going to be advocating for practice and policy change, right? Little P's, big P's. Everyone still taking this information back to their organizations. I know I heard something to take back to AAP from Sherry. So I will be doing that, I promise. And smaller group looking to to contemplate or implement immediately, but really excited that I think we've captured a lot of people's attention with this. All right, so moving forward, we have stretched our brains. Now it's time to stretch our bodies. Get ready to move through space with us on a 3-minute guided spacewalk. After we glide and float through the atmosphere, we're going to take a short intermission. We will be back at 2:10. All right, spacesuits on.
Imagine yourself on a launch pad. Sit in your chair and vibrate up and down. Shake your arms. Bounce your feet on the floor. Twist and rock and roll. Feel the power of the coming blast off. The shuttle oscillates at 3 times per second during launch. Feel the vibration in your whole body. We've blasted off. Stand up out of your chair. Stretch for the sky. Count to 3. 1, 2, 3. Sit back down. Imagine reaching new heights as you blast off towards increasing HPV vaccination rates. Do the cycle 2 more times. Stand up. Stretch for the sky. Sit back down. Stand up. Stretch for the sky. And remain standing. As you stand, stretch your arms out wide, as if you are an astronaut floating in space. Visualize the entire landscape of HPV vaccination partners and clinics and adolescents below you. Slowly sit back down in your chair and draw your arms in. Look at the vista before you. Twist to the right, thinking of the enormous scope and the importance of the mission. Twist to the left, thinking about the upcoming steps of the mission and conference. We now return to Earth. This is the final time for reflection on our journey to immunity and beyond. Gently spin around in your chair or stand up and walk around. Stretch your muscles, look up at the sky or look out a window and reflect on everything that you are learning from the 2021 meeting. Thank you for taking this spacewalk with us.
Hi, my name is Kelly Danielkor. I am a high school senior in Los Angeles, and I am the founder of Vaccinating, as well as a Unity Consortium teen advisor, and this is Teens and Vaccines. So who am I? How did I get here? 2 years ago, at the age of 16, I discovered a post on Reddit, which led me on a whole journey to Vaccine. I was already interested in public health when I just came across a question from one of my peers who had anti-vaccine parents asking how could they get vaccinated. They were concerned for their own health as well as those around them. And they tried to convince their parents, but had no success. I was just in awe. Teens were saying what we all want to hear. I want to get vaccinated. But they really needed help and resources to do so. And I was inspired, amazed, and I decided I needed to do whatever I could to help. I myself have pro-vaccine parents, and I think I never realized, and I really took it for granted that was sort of that part of my health was something I was guaranteed and I didn't need to fight for. And so I wanted to do whatever I could to help my peers. So as I dug in, I realized quite how common this was actually in this phenomenon. And this is obviously pre-COVID as well, and this desire among young people to get vaccinated. And so I tried to help however I could, creating resources, the forms of guides for talking to parents, for figuring out what vaccines one needs to catch up on, and for deciphering minor consent laws for getting vaccinated in each state. And so I think this really shows a lesson to all of us, both in these Reddit posts and now what we're seeing. We see teens participating in COVID vaccine trials. We see them helping those in their community get appointments to get vaccinated. We're really seeing this involvement, and we're seeing the impact of vaccines on their lives. And I think not only is this important in terms of sort of a COVID vaccination, but also in combating these falling rates of HPV vaccination as well. I think the COVID-19 pandemic has really served as a sort of startling public health lesson on not only on the importance of vaccines clearly, but that we each have really a responsibility to prevent the transmission of a disease, whether through sort of social distancing or vaccination, to ensure our collective health. And as we push for increased immunization, teenagers can and should have a role to play. I know everyone around me, even when we were told that sort of COVID was not something we were at risk, the sort of larger risks of it weren't something we really needed to be worried about as young people, we all stayed home to protect those in our community who were at risk. Though obviously now we all know that young people really do feel the impacts of the pandemic, both in sort of sickness as well as the impact on everyone's lives. But I think there's something really important to consider, and this role and responsibility young people feel to be vaccinated. And then especially as we look at the HPV vaccine, which is a stigmatized form of healthcare, I think every young person also deserves the right to be healthy and to prevent sort of having cancer. And so studies show that really a majority of adolescents believe vaccines are important to protect both themselves and their communities. And they also consistently show that they are eager to be more involved in this decision-making process. So it really raises this very important point, the importance of our outreach efforts, reaching and involving teens. So vaccine advocacy really almost always focus on parents as the sole decision makers. So young people want a voice, not simply to protect their own personal well-being and health, but to help prevent preventable diseases for everyone. It's time we reorient our efforts to co-create with and give a voice to those already passionate about this issue and work to reach those in need of information and education as well. So after all, we are the next generation of parents. So as attendees of this meeting, you really are the people that teens will want answers from and teens will look to and that are in the best position to help. And so I think it really comes down to three main ideas: educate, support, and advocate. You are a resource for all of these teens and adolescents. You are the best place of support. Be someone who supports them, advocate for their rights in terms of laws, but also advocate for them in a medical, sort of clinical decision-making setting. Advocate for them to be part of this conversation. Empower your patients. And so I think this is something that like we really need to recognize. So this is the next generation of parents, and these are also teens are in their own homes. We talk about vaccine hesitancy. They are the ones who know how to combat this best. They know sources of hesitancy best. And so I really think this is a time we need to empower teens to be involved in this decision, to have and give them a voice. And so thank you so much. You can find more information at vaccine.org, as well as on Unity Consortium's website, and you can find us at Vaccine on really every social media platform. Thank you so much for listening.
That was fantastic. Several of our member organizations work with teenagers and young adults. Kelly is such a great example of what we can do when we harness the talent of young leaders. I really love what she said about the teenagers of today or the parents of tomorrow, and really talking about building that generational belief in the importance of vaccines and the understanding of how vaccines can help keep not just the individual, but the entire community safe. I thought that was really fantastic. We have one final knowledge check before we introduce our last panel of the day. What 3 evidence-based interventions are recommended by the community guide? So pull out your Slidos and see what you think. Client reminder and recall systems, paper immunization records, provider assessment and feedback, provider education when used alone, vaccination programs in schools or childcare. And we have almost 300 people on the line, so please get voting. Oh, there we go. And people are really liking client reminder and recall systems, assessment and feedback, and vaccination programs in schools and childcare. And those are excellent answers. I think it's, people are not very supportive of client-held paper immunization records, which is of course the way all of our COVID vaccines are on these little index cards, hopefully also entered into state registries. So we'll have a little bit more of a permanent record there. Excellent. And the top 3 that people chose actually are the correct answers. Reminder and recall tends to be most effective when done centrally. Sherry talked about how difficult it is for an individual clinic, the manpower required for reminder and recall. And that has been some of our experience as well. When you have a small clinic trying to do reminder and recall with a limited staff, that can be very difficult, but centralized from immunization registries can be much easier and more effective. Provider assessment and feedback is also very effective. People, if you don't know that you have a problem, you will not try to fix it. And providers can also be competitive and want to do well. You know, they're used to trying to do well in school, and they like the competition and to see how they're doing and to watch themselves improve. And then vaccination programs in schools and childcare are less common here, but have been extremely effective in other countries. If you didn't get all 3, it's okay. We are all constantly learning from one another. That's why we're here.
That's right. And I would say education combined with these interventions is a good thing, but not
yes,
alone.
It's actually crucial. Yeah, you need education to get buy-in to the other things. It's just if you have sort of a one-off CME lecture and then no follow-up, it's not enough to change behavior.
Which is why we're going to get everybody to some action items by the end of today.
Exactly.
All right, I'll stop talking.
Oh no, we like you talking, because that was actually a really important point. Joining a learning community helps when you're trying to achieve difficult goals. So in 2020, 8 health systems joined a national HPV learning collaborative. There were challenges, there were wins, and there was sustained commitment, because we know, like HPV, you need to be persistent to achieve results. We will now hear from AMGA's analytic and population health team members on lessons learned. Dr. Siemens, take it away.
I'm Elizabeth Siemens, and I'm the Vice President of Research and Analytics with AMGA. Today, together with 2 of my colleagues, we are going to talk about an HPV vaccination best practices learning collaborative. And I will let my colleagues introduce themselves when they come up. Who is AMGA? We are the American Medical Group Association, a 501c6 trade association, and our members are healthcare organizations, multi-specialty medical groups, integrated delivery systems, as well as academic medical centers. We work with our members around population health, helping with that movement from volume to value. As part of that, we work on quality improvement, and we conduct a number of initiatives, one being shared learning collaboratives, and that's what we're going to focus on today. These are intimate gatherings of our members, about 10 to 20 groups get together and work on a specific issue, in this case, HPV, but there's a number of others that we've worked on. We also conduct national campaigns around a specific area. These are lighter touch, more participation, and we have one coming up this fall on adult immunizations, and we may have an opportunity to address adolescent immunizations as well. Research and analytics is the department that I sit in, and in here we take data from our members and pair it with shared learning, and that's exactly what we did for this HPV Best Practices Learning Collaborative. We also conduct research, usually in partnership with an academic medical center. We work in measure development. Mostly we want to sit at the table around measure development and make sure measures are meaningful on behalf of our members. And we also do implementation studies, and these studies are to implement and translate evidence into practice. We have over 400 members, 175,000 physicians. Our member organizations are of varying sizes. And really our members are all working towards improving population health, where it's their business strategy. And that's what we do, is support them in this endeavor. So here are some of our members. And here are the 8 members who participated in the HPV Best Practices Learning Collaborative. So how did we get here? So I mentioned that we have a history in best practices learning collaboratives, and we did a number on adult immunizations. We started with a pilot, we wrote that up, then we went on to scale up and spread 2 more cohorts of about 20 organizations each. And after this work, we were invited by the National Adult and Influenza Immunization Summit Steering Committee to present at the National HPV Vaccination Roundtable Integrated Delivery System Task Group. They knew what we had done. This task group was interested in trying to figure out how we can work with health systems on improving HPV vaccinations. So we presented what we had done in the past on with adults, and decided to partner and come together and create the Best Practices Learning Collaborative for Adolescent HPV Vaccinations. And this was done obviously in partnership with the HPV Vaccination Roundtable, as well as the American Cancer Society, and supported by CDC and OIDP. So the objective of our program was develop and implement evidence-based strategies and interventions to improve adolescent HPV vaccination rates in multi-specialty medical groups and integrated health systems. And we did this using our best practices learning collaborative framework. So what does that entail? So if we start at 12 o'clock here with the advisory committee, we were lucky enough to have partnered with the National HPV Roundtable, which already had a number of experts who were happy to participate as advisors in this learning collaborative, and really helped us with everything that we did as in the collaborative. Next, about 1 o'clock, you can see measurement and QI tools. So the advisors helped us choose the most appropriate things to measure, as well as what qualitative tools we would be using. We do outreach and coaching to the groups and by AMGA and by our advisors. Typically, we have in-person meetings with networking. Of course, we had to shift quickly to virtual. We were lucky enough to have our first kickoff meeting as an in-person meeting, which gave us the opportunity to meet each other, but then had to pivot to virtual. We normally conduct our site visits in person, but we did those virtually, and they really were a smashing success. We have webinars monthly or bi-monthly in this case. We share tools, we share resources, and in the end, we sort of wrap it up with case studies, a white paper, publications as appropriate. But really what this is all about is benchmarking and shared learning. And I can't emphasize enough the importance of shared learning, and that's really bringing all these different organizations together, letting them see how they do on measures in relation to each other, but also learning how different groups made that happen, sharing strategies, sharing lessons learned, et cetera. So now I'm going to turn it over to my colleague, Elaine Chambers, who is going to talk about some of the specific quality improvement activities.
Hello, everyone. My name is Earlene Chambers. I'm the Director of Clinical and Quality within Population Health Initiatives within the AMGA Foundation. And as Elizabeth mentioned, one of the major components of the HPV Best Practice Learning Collaborative is quality improvement. We coach members in developing their HPV program in several ways. As you can see here, we have outreach calls, emails, virtual site visits. The outreach calls and the emails were very important to connect with our members throughout the collaborative. We learned a great deal from those. We kept them motivated, and we learned what are some of the challenges. Because of COVID, we had to do virtual site visits. Prior to that, we would go to the organization and meet with their entire team to learn about all the work that is being done behind the scenes. But because of COVID, we had the virtual site visits. This was our first time, and it was great. We still got a chance to meet with all of the team. We were able to learn what they did in their program. We were also able to provide learnings from other groups to help them in areas where they have some challenges. The QI documentation and reporting part of the collaborative is also very important. At the beginning of the collaborative, QI charter and project requirement documentation was needed. This was to add structure for the groups in their programs, but it required them to meet with their teams and really look at what they wanted to do and answer those questions of what, when, how, where, and why. And once they submitted that project requirements in the charter, then throughout the collaborative, they were required to submit their action plans. Now, the action plans was a working document, and this included knowing what the goals were, knowing what your objectives are, and knowing what your interventions are, and implementing those. This was submitted bi-monthly to the AMGA team, which it really helped the AMGA team to learn about what the groups were doing throughout the collaborative and to be able to look at all the ways that they have been successful, what are some of the challenges, and as Elizabeth mentioned, to be able to share that information with other groups. The PDSA cycle and the gap analysis is one part of the QI process. In this collaborative, we did not require them to submit their document, but we also encouraged them to do a PDSA cycle and a gap analysis as a support for their QI improvement. So our collaborative interventions for the groups came in 5 different buckets. Despite COVID, the groups were able to implement interventions in these areas of education, patient outreach, gap closure, visits, and EHR resources. Education is a part of all of our collaboratives, even though we do know that education alone cannot move the needle in the collaborative. So it needs supporting interventions. As you can see here, their education came in provider and staff education. There was community meetings, provider department meetings, clinical staff meetings, and there was even peer-to-peer coaching. And this peer-to-peer coaching was between providers. They also implemented weekly newsletters. Patient education was focused really on, because of COVID, with letters, text messages, emails, MyChart messaging, and these messages out to patients was to try to get them to come in for scheduled visits if they were overdue or if they were due. Lots of education occurred at the point of care because when they had them there at the office, they took the initiative to educate them about the HPV vaccination. This not only occurred through the front desk staff, this occurred through providers and the clinical staff as well. Patient outreach was another bucket for interventions with phone calls, MyChart messaging, and letters. Phone calls was a predominant method of outreach because of the COVID. All of the groups participating in the collaborative did multiple phone calls to their patients with the focus to try to get them to come in to schedule visits and also to give them information in regards to their immunization statuses of their child. Gap closure was important as well. These are 3 reports that were developed to close the gaps for HPV. The first one, which is One More Dose Due, was a report that would look at what is one more dose due for that patient to complete the series. This report was used to try to call the patients to have them come in to complete their series for HPV vaccination. Now, the enhanced pursuit list occurred at the time at the point of care. This was used to, at pre-visit planning, to look at those patients that were coming in that were overdue for their vaccinations or were due. And they used this list to target those patients to ensure that they got their appropriate vaccinations when they were in the office. The missed opportunity report was another report to look at if patients did not get their vaccination when they were in the office. What was the reason behind that? How can they do better? And to also monitor that over time to see if they're making up for all those patients that have missed their vaccinations. And then we had the visits. Visits were very important due to COVID. Some groups had telehealth visits, and that was the preliminary part of the visit that they could do without having to come face-to-face with the patient. There were weekend visits where Saturdays and Sundays where they opened their clinics to make people feel comfortable, and also to be flexible and allow parents to bring their kids in to get their vaccinations. We all know about the well and the sick child clinics and where you're separating clinics to ensure that there was not a crossover during COVID between the sick child and the well child. Drive-through clinics was also tried and was successful in one of the groups. And then there was the focus on well child visits. And the thought here was if we can focus on well child visits, immunizations will be part of that, and we can improve our rates just by focusing on getting those kids in for those visits. The EHR resources were health maintenance alert and best practice alerts. It wasn't that they didn't have these alerts already established in their EHR, but what they did was they brought it was at age 13. So they changed those best practice alerts and health maintenance alerts to be at 11 to 12. So the doctors, this is a part of the education process, is to make sure that the doctors are aware that instead of vaccinating starting at age 13, that they would start at 11 and 12. Dashboards, and scorecards were also created, additional information for the provider. And last but not least, but very important, was the transparent reports, in which was done at the provider level so that providers, not only providers and staff, they could see where they are in their rates of HPV vaccination. And also they can see where they compare among all of their other peers. So right now, I am going to turn this over to my colleague, Corey Rattleman, who will talk about data. Thank you.
Great, thanks, Erlene. My name is Corey Rattleman, and I'm the Senior Research Analyst that supported this collaborative for AMGA. I'm going to talk to you today about the performance of the organizations, and I'm going to share with you the average performance and highlight improvements for the collaborative over the 15-month intervention period. So I want to start by focusing on the patients. So across the 8 organizations, they touch more than 128,000 adolescent pediatric patients aged 9 to 17. And here is sort of the age breakdown for that. So about 52% of patients were 13 to 17-year-olds, 26% 11 to 12, and 22% 9 to 10. And now I'm going to shift to talking about the measure rates, but I'm going to keep that population up there because remember, those are actual children and shots in arms. So we started by measuring HPV initiation and completion, or up to date, by age 13, and then for adolescents 13 to 17-year-olds. And this was just to reflect what we see with the NIS teen survey, national data, and then also the HEDIS measures for adolescent vaccinations. And you'll see for each measure here, we have 2 bars. So over here, these dark green bars under HPV initiation by 13. The one on the left is going to be the vaccination rate at baseline, which was 2019 Q4, so the 12-month ending December of 2019. And then the bar to the right of that for each measure will be the latest data reported, which came from Q1 of 2021. So you'll notice, as everybody's mentioned, COVID is right in the middle there. So pretty much all of 2020 was significantly impacted by that. We got together in February of 2020 for our kickoff meeting. And when we talked there was a lot of discussion on vaccinating younger patients. So a lot of the organizations were really excited about the opportunity to kind of shift their focus towards these younger patients. So we did add a couple of measures. We added HPV initiation for patients 11 to 12 and completion of the series for 11 to 12-year-olds, and then also HPV series initiation for 9 to 10-year-olds. And so you can see the 2 bars for each of those measures. And you'll notice that the collaborative improved in all measures for adolescents age 11 to 17. So despite sort of the timing with COVID, they were able to achieve that. And the highest relative improvement we saw were for the by age 13 measures. Both HPV initiation by 13 had a 14% relative improvement, and then a 15% relative improvement for HPV completion by age 13. And then we wanted to kind of put this into a number of patients. So we look at each of the organizations and the improvements that they made on the individual measures. And we see how many patients that would have impacted. So for 11 to 17-year-olds, we see that there would have been 5,100 additional patients that initiated the HPV series. Again, among 11 to 12 and 13 to 17-year-olds. And this is as a direct result of the improvements made during the collaborative. And then 5,000 additional 11 to 17-year-olds that completed the HPV series due to those improvements. So that's something we're really proud of, and I know the organizations are proud of. So now we're going to shift, and we're going to look at some individual organizations and kind of use their experience in the collaborative to demonstrate some concepts that we think are really essential for successful quality improvement. And the first is that you can't improve what you don't measure. So this first organization had never looked at HPV vaccination rates, which was common among several of the collaborative members. So they kind of expected their rates to be low. They know they have some regional challenges. They took a look and estimated the measures. So here I'm showing HPV initiation and completion for 11 to 12-year-olds and HPV initiation and completion for 13 to 17-year-olds. And these are their baseline measures. They saw the data. They were a little surprised how low it was. But then we got together in February and we benchmarked their data against all of the other 7 collaborative members. So everybody had their rates fully identified. And they were really shocked with not only the fact that they were the lowest among the 8 groups, but really there was a significant difference between where they were at and then the next highest group. They also had the lowest rates relative to state and national benchmarks, so looking at the NIS data. So they took this data home in February and the benchmarking report and shared it with their providers and staff, and nobody was happy. So they really wanted to get going and get started on kind of pushing those rates up right away. In April, just a few weeks later, the COVID national emergency was declared. So even though they had done a lot of great planning and continued to plan throughout the collaborative for a lot of their IT improvements, things to support transparent reporting, best practices alerts, some electronic outreach to patients. A lot of that stuff was stuck in the queue during the pandemic, as it was for a lot of groups. So really, they were able to kind of meet with their providers, do provider education, some patient education, and really just get everybody focused on HPV. So a lot of the improvement came from the fact that people just didn't like being where they were at relative to the other groups, and they were really motivated to make a change. So in the end, this organization improved rates for all adolescents 10 to 17 years old. And that ranged from 3% to 16% absolute improvement across the different measures. So you can kind of see them highlighted here. One exciting area is that they tripled the rates of completion for age 11 to 12-year-olds. So that's for the HPV series completion. You can see they went from 7 to 23%, and that reflects 1,000 more 11 to 12-year-old patients just at this one organization that completed the HPV series as a direct result of the improvements that they made. They also closed that gap with the state NIS teen rates by about 65%. So you can see here the two light blue lines represent that state rate for HPV initiation and then completion, and you can see them marching towards that. So I'm hoping they'll close it here soon. And then as a bonus, they improved the rates for established vaccines. So we also measured vaccination rates for meningococcal vaccines and Tdap. So these were sort of used as an internal benchmark for the groups, so that they knew kind of what can you expect to reach in terms of vaccination rates within your organization for adolescents. So they improved meningococcal vaccination rates from 44% to 59%, and their Tdap vaccination rates from 75% to 85%. And again, this was really by measuring was the biggest thing that they were able to do, and really jump-started their efforts. So in order to improve something, you have to measure it. Super helpful if you can benchmark it against other organizations or at least some national data or quality measures, and then share that internally. You'll really see that it can motivate folks. So this leads me to my next example, that providers are motivated by competition. So sometimes that competition is internally. So this organization is a provider-owned healthcare organization. On the flip side, they started out at a very high rate. So they started with the highest HPV initiation for 11 to 12 by 13 and 13 to 17-year-olds across the collaborative. They also were above their state and national benchmarks for HPV and also meningococcal. We're showing the HPV state rates here with the light blue lines. You can see how they're doing. And they did this by really using a robust transparent reporting. And their transparent reporting was focused coming into the collaborative on the percent of patients that had their well visits. And by having their well visits, they think that patients are more likely to meet their prevention measures. So they're more likely to get their vaccinations. And in fact, that's what we see. And even though they started out at a super high rate, they continued to make steady incremental improvements throughout the pandemic. And that was by really focusing on HPV, doing provider and patient education, and outreach. So again, a lot of their IT improvements got stuck in the queue during COVID, and they were really able to do this because they have that transparent reporting, focusing on well visits, and now they're talking about HPV. They also met their individual goals for HPV initiation 11 to 12 and by 13. That means that they reduced their unvaccinated patient population at baseline by 20%. So you can see those highlighted there in yellow. And really, this is just an example of why transparent reporting is, when done right, can really be successful. So in order to be successful, transparent reporting needs to be transparent down to the provider level and the staff level. Those reports need to be pushed out. Don't rely on the providers to pull that data. Use that data to set goals to achieve an ultimate outcome. If you want to meet an 80% HPV vaccination rate, don't set it at 40 or 50 for the providers. Tie that to value-based compensation if possible. And then the most important thing is provider and staff must trust the data. So work with them, show them their data, and make sure that they trust that that reflects what they're doing on the ground. Now I'm going to hand it over to Elizabeth, who will walk you through one more example.
Thanks, Corey. In this last example, I'm going to talk about leveraging a culture of rapid change and transformation. So at this organization, you can see that they started with the second lowest rates in the collaborative to start. But they ended up improving in every measure. As you can see, they shot past their individual goals for the HPV series initiation and completion by age 13. That's what's highlighted there in yellow. They improved up 24% and 19%, which is huge improvements on those two measures. And then, despite COVID, they were the only participant to improve in the 9 to 10 age category. So that's there on the far left, it's highlighted. They improved, they were up 8% from 13% to 21%, which was an amazing improvement for a really hard age group to move. So how did they do this? Well, this organization had a culture of rapid change and transformation. They were an agile organization. We've worked with them over the years. One thing that they did in this case was setting expectations for parents and patients early. So the very first time that a parent came in with their infant, they were given a book or a booklet that laid out everything that was going to happen in their tenure in pediatrics. So all the vaccinations that were coming in all the time frames. So they knew what to expect and they knew what was expected of them from the very start. They also, as in the previous example, did transparent reporting, and it was expected. It was part of the culture at this organization. So physicians and providers expected to see what their rates were so that they could compare with their peers, with themselves, and across practices and across the organization. They also gained leadership buy-in and support, which is really important. And we encouraged all organizations to start at the top and really get leadership to agree and support the programs. And that really switches when you get to the clinical practice team to a concept of ownership. So fostering ownership for an initiative is really important. And that means inviting everybody to participate, inviting everybody's input from the beginning. So it's not buy-in, but it's really owning a project. And this includes everybody throughout the practice team so that when parents or patients come in, they're receiving the same message, a unified message across the practice. And they were really able to maintain this agility for rapid transformation. Another example from this group is in a previous collaborative on adult immunizations, they used standing orders. And instead of just implementing it as a way for nurses to give shots, they really thought about it as a way to empower the workforce. So, and this gets back to that idea of ownership, where the nurses now felt empowered and they really owned the process by being given that ability to give shots themselves without having to check with the provider. And they also were open to feedback from everyone in this collaborative and others, and they left time for reflection and sense making along the way. And all these things really contributed to this culture that really allowed them to be successful, not only in this initiative, but in other initiatives. So to summarize, we know benchmarking is key. Facilitated shared learning is where the magic happens. You can't say that enough. It's really bringing organizations together to learn from each other and share, and also see how they're doing through the benchmarking process. You can't improve what you don't measure. It might be something as simple as just looking at your data, and that can have an impact. Providers might be motivated by competition. It might be with themselves. It might be with their peers. It might be across practices. It might be across, the whole organization. And that's where the transparent reporting comes in. And finally, culture change is slow, so start now. There's a lot of little things that you can do that will impact not only this and your current initiative, but future quality improvement initiatives and programs across your organization. So here's our team. We want to thank you for this opportunity to be part of this collaborative, for the partnership, and for this opportunity to present our findings. Feel free to reach out to us with any questions. And thank you for your time. Have a nice day.
Thank you so much. Our program is so full that we don't have time for live questions with this panel. We will take your input and share with the speakers, and the HPV Roundtable staff will post FAQs after the event. Thank you to the participating health systems that worked so hard this past year to keep HPV vaccination a priority. Now I want to introduce you to our next speakers, Rachel and Annabelle Marie. Welcome.
Hi, my name is Rachel Murray, and I'm the mother of Annabelle Murray. Annabelle, who is 10 years old, has been a patient at St. Jude Children's Research Hospital since she was 3 months old. She has spent most of her life undergoing treatment for severe chronic neutropenia, a rare blood disorder that leads to low white blood cell counts, which makes her prone to infections. Annabelle has spent a great deal of time in hospitals in her young life, and she's overcome many obstacles. Her disease was not preventable, but her care team is doing all they can to make her life as normal as possible. I would do anything in my power to make her future bright, optimistic, and pain-free. When Annabelle's physician at St. Jude asked me about her receiving a vaccination to prevent HPV cancers, I didn't have to think twice. I knew that HPV vaccine prevents a number of adult cancers. She's been through so much already, and I don't want her to experience something later in life that could have been prevented. The HPV vaccine can be best described as cancer prevention. HPV vaccination is especially important for childhood cancer survivors who are at greater risk of second cancers. When I hear those words, I think of the easy decision I made in the clinic to get Annabelle vaccinated. It was simple and only took a few minutes. That means one less thing for Annabelle to worry about in her future, which gives me peace of mind. I was excited to learn about the launch of the St. Jude HPV Cancer Prevention Program and was thrilled for Annabelle to be featured in a hospital magazine about the program. I know they will do great things and help spread awareness about the importance of the HPV vaccination in preventing adult cancers. I recommend to all parents, whether your child is a cancer survivor or in good health, to get your child signed up for the HPV vaccination when they become eligible. Our children are our future, so let's help make it one in which the rates of HPV-related cancers are drastically reduced. Thank you.
And thank you, Rachel, for sharing your story and that of Annabelle's and really helping other parents understand the importance of HPV cancer prevention through vaccination. Appreciate all your work around that. And St. Jude as well. All right, Rebecca, as we near the end of our journey, we're going to try to set everything up about what we've learned. I know, for me, one of the sort of takeaways, big takeaways from today was thinking about data and, the interesting uses of data and how to look at smaller and smaller geographic areas, thinking about rural areas, thinking about not just variation between states, but within states and within counties. And then, hearing last bit from the AMGA Learning Collaborative about the importance of really drilling down and showing that data both at the clinic and the provider level, and the importance of doing that. And so I think that's been one of my big takeaways. And how do we make sure to continue to leverage data and get the data that we need to demonstrate the rates and how we can make change.
Yeah, I know providers we gave providers their own data in our intervention, and they really appreciated that. And it did. What was interesting is at the micro level, you can see variations by provider that are as big as you see, between states and between clinics within systems and systems within states. So we really know what works, that, consistent, strong messaging and offering the vaccine at every opportunity. And it's just a matter of making sure that gets to everyone, so everyone has an opportunity to vaccinate. So anything, parents may still say no, but it's on us to make sure that they have every opportunity to say yes.
Yeah, I love that point about sort of, we know what works, right? All these provider reminders, strong recommendation, why am I blanking on the word for standing orders, right? And then how do we find where the places that need these interventions the most, be them physically or specific groups, as we talked about yesterday. And I think the other thing is, now that your panel brought this up too, is how do we then apply that to a younger age group starting at age 9 to 10 and bring those same practices to that group to improve rates?
Yeah,
really,
and I think,
yeah.
Oh, go ahead.
No, you.
No, you.
That was it for me. You go.
Okay. So I think really the advantage of 9 is that not everybody comes in all the time. And so it just gives you more time. We all want more time, and this just gives you more time to get it done before, you lose the kids to not coming in every year, which as they get into older adolescence, a lot more kids miss visits. You know that better as a pediatrician.
Absolutely. Yep. Harder and harder to get them, as much as we like to see them. All right. I think we're going to have to move on and start wrapping things up for this public session today. Rebecca, is there anything else we need to do?
Our time together may be ending, but there is work for you to do. Like yesterday, the HPV Roundtable is calling on each one of you and the organizations you represent to take action now. Similar to a strong recommendation for HPV vaccine, we want you to leave with a clear plan for something you can do today. First, share the information. Second, do a deeper dive of the research presented here today. We link to additional readings directly from the agenda on our website. 3, convene leaders and decision makers within your organization to discuss what you can do to get adolescent vaccination back on track. 4th, make the dream a reality, develop an action plan to create change, which is crucial because if you don't have a plan, you will not be able to actually get what you want done. And lastly, we'll be asking you at the end of the transmission to complete an evaluation of this meeting. We love feedback, so please make time to tell us what you value about this meeting, what the meeting brought to you and your organization.
All right, who here is feeling inspired? Time for audience check-in with our Slido. We hope you've learned something new and we're really feeling motivated and empowered to take action to increase adolescent vaccination. But before we adjourn this public session, want to do one more Slido word cloud. So if you had to choose just one word to describe your takeaways, what would it be? Grab those phones, log in one last time, and give us your thoughts. Ready? Somebody's ready again. I thought that was mine, but I haven't even a chance to put mine in yet. Excellent.
I like that people are feeling empowered and motivated. That's wonderful. Inspired to take action. We're so happy.
Energized, encouraged. This is good. I feel like we shifted a little bit more to the positive words as we made it through our session
you can
today.
Do it.
So fabulous. Other data, exactly, right? I think that message was driven home through each of the different panelists today, the importance of really looking at the data at many different levels.
Yeah.
So completely agree about
partnership also, and fine at age 9.
Ooh, that's a keeper. We're going to screenshot that one.
Excellent. Well, you don't need a fancy transmitter to stay in touch with us. You can find the HPV Roundtable on Twitter, YouTube, Facebook, and Instagram. Be sure to check out the HPV Roundtable TV on YouTube, where you will be able to find panel recordings from both days.
We leave this meeting knowing that with your help as HPV vaccination champions, we can reach new heights together in HPV vaccination. Thank you for your commitment to preventing HPV cancers. Please take a few minutes now to complete the brief meeting evaluation. It's really important to us. To our officially designated HPV Roundtable members, you will be called back into orbit in 20 minutes. For our members
only.
Your
mission is not concluded. Please remember to come back.
That's right. For everybody else, this is Mission Control signing off.
Safe travels.